And we are live. Good evening. I'm currently talking to no one, which is fine. I can appreciate that. It always takes people get a notification and then they're like, oh, and at first we would just start talking off the bat, hi, welcome. And it's like, no one's here. So,
see, Vlad, now we know. Why we didn't make
now you know the secrets.
The first cut.
So if you're just joining us, please come on in, grab a seat, hors d'oeuvres and drinks are on the bar. Non-alcoholic, of course. Hi, Katie. Good to see you. Lead advocate, Katie. We will start, as always, in just a couple minutes. Let the room fill. In the meantime, let us know that you're here. Hi, Dave. Good to see you. Let us know that you're here, where you're from. And I was thinking about this today, a favorite flavor jelly bean. So, because we always go. And while we're waiting, I think we'll have to ask our folks. Mike, you're hard at work trying to determine what is your favorite flavor jelly bean?
You know, I wish I knew what the flavor was, but I'm going to go with a color. Green.
Green.
I don't know what the flavor is, but green.
The jelly beans at the bank all taste the same. And they always did when we were kids. They're like, you were like, this is weird, but green. Okay. Jeff, what do you think?
I'm super boring. I think just like chocolate. Vanilla is my favorite ice cream. Chocolate's probably my favorite jelly bean.
Chocolate jelly bean. Interesting. Evelyn.
I'd say the buttered popcorn.
Ooh, that's a good one too.
Because it creates confusion, right? You're thinking you're biting into something sweet and then boom, it gives you like salt.
Vlad?
For us, it would be glutamate. What else?
Glutamate. Of course, glutamate favorite jelly beans, our favorite. That's next on the trial list is a jelly bean that reduces symptoms for OCD, and we would love to see that. And by the way, Evelyn, I'm super excited because I was going to answer popcorn too, so love that. Real quick, Katie strongly is like jelly bean. Hey, love Lana, good to see you. Kayla from Alberta. We've got just above. I apologize, I missed Belinda from Princeton. Julie's here from Watermelon. It's her favorite.
Watermelon. That's my favorite.
Yeah.
I take
I
it back.
love going to Watermelon.
Watermelon.
Is my favorite place.
She's from Watermelon. Everybody, buttered popcorn is a popular one, Evelyn. I think we're in the know. And we have Frode. I hope I got that right, from Oslo. So welcome. Is it late there? Is it morning there? All right. With all of that, thank you so much for being here. Please continue to jump in, say where you're from and your name. With that, let's get started. We have a lot to talk about tonight. My name is Ethan Smith. I'm a national advocate for the International OCD Foundation, which simply means I have OCD and I won't stop talking about it, at least, for the next year or so. Quickly, some housekeeping. This town hall is intended to serve as educational content and is not intended to replace therapy. For treatment-related questions, please be sure to work with your local provider or contact a local clinician. The National OCD Foundation is not a crisis hotline and should not be used if you're in distress or feel unsafe. If you're in a crisis or ever feeling suicidal or unsafe, please go to your local emergency room, call 911, or call the suicide prevention hotline at 800-273-8255. Jess, if you want to flash that on the screen real quick, that would be helpful. Thank you. And as always, we want to be respectful and kind of others. This is a roundtable discussion, but we will be looking at questions from time to time. Please keep in mind that this is a public forum on social media platforms. But with that, we are all here to support one another. And so be respectful, be kind, and be considerate. And with that, we are ready to start. I'm super excited about this panel. This is the Future of OCD Treatment Roundtable, Volume 2. That would indicate there was a Volume 1, which you can view on our social media platforms and pre-recorded. But this one's live, so we're glad you're here live with us. Let's get down to it. Let me start the introductions of our very distinguished panel. First, we have all the way from north of us, Dr. Evelyn Stewart. She's a child, adolescent, and adult psychiatrist and a clinical and neuroscience researcher. She's a professor of psychiatry in the Faculty of Medicine at the University of British Columbia and is a founding director of the British Columbia Children's Hospital Provincial OCD Clinic and Research Program in Vancouver, Canada. Dr. Stewart is also the research director of BCCH, Child, Youth, and Reproductive Mental Health Program, and a member of British Columbia Mental Health and Substance Use Services. She has authored over 130 original papers, reviews, and chapters on family, clinical, and treatment aspects of OCD throughout the lifespan. Dr. Stewart, thank you so much for being here.
Thank you for letting me in.
Yeah, we do what we can, Just don't
Excellent.
take it for granted. Yeah. Mike Hetty is the co-director of the Anxiety and Stress Disorders Institute. For over a decade, he has specialized in the treatment of OCD and anxiety disorders. He is a clinical fellow with the Anxiety and Depression Association of America and a member of the International OCD Foundation. He has extensive training and experience with cognitive behavioral therapy, exposure and response prevention, and acceptance and commitment therapy. He presents educational workshops for professionals and the public, runs group consultation for therapists, and guest lectures about anxiety and OCD. Thanks so much, Mike, for being here.
Thanks for having me.
You love the world, apparently.
I love the world multiple times.
Yes. There are multiple Earths. We can talk about that later. Next, we have Dr. Vlad Korik, MD. Vlad is the Chief Executive Officer of Biohaven Pharmaceuticals. Dr. Korik has more than 20 years of drug discovery and clinical development experience at Yale School of Medicine and Bristol Myers Squibb prior to leading Biohaven. Since July 2001, Dr. Korik has also continued to serve as associate clinical professor of psychiatry at Yale School of Medicine. He previously served as the inpatient chief of the Yale Clinical Neuroscience Research Unit and the director of the Yale Obsessive Compulsive Disorder Research Clinic. He has served as president of the Connecticut Psychiatric Society. He has authored more than 65 peer-reviewed publications, has earned his medical degree from Wake Forest University School of Medicine. He completed internship at Yale New Haven Hospital and residency training at the Yale Psychiatry Residency Training Program, where he also served as the program-wide chief resident of the Yale Department of Psychiatry and chief resident on the PTSD ward at the West Haven, Connecticut Veterans Administration Hospital. Dr. Korik was an honors scholarship in neurobiology and physiology at the University of Connecticut, where he received his Bachelor's of Science degree. Vlad, it's a pleasure to have you.
Ethan, thank you so much for having me. It's an honor to be here. You know, my whole research career started in OCD, so it's great to be back here.
Well, we love having you and welcome home. And last but certainly not least, we have Dr. Jeff Szymanski. For the past 11 years, Dr. Szymanski has been the executive director of the International OCD Foundation. Previously, he was the director of psychological services at McLean's Hospital OCD Institute. Dr. Szymanski is also the author of the Perfectionist Handbook based on his work at the OCD Institute. He is the immediate past president and co-founder of the ACBS New England chapter, which provides education and peer consultation on acceptance and commitment therapy for a regional audience. As a clinical instructor in psychology at Harvard Medical School, Dr. Szymanski has supervised pre-doctoral psychology interns, psychiatry residents, and has run cognitive behavioral therapy seminars. Jeff, you may do better here. It's not trivia.
That is unlikely. I always win at trivia.
It's not true. He comes in 8th every time. He holds a solid, firm grasp on 8th position. And Ashley, I like green apple jelly beans as well. With all of that being said, let's get started. We're very excited to talk about the future of OCD treatment. Before we do, however, I think it's important to talk about where this all came from, where we started, and how we've advanced to today. Gonna start with Evelyn, actually, because we all start out as kids. I don't think any of us skip that part of our lives. And Evelyn, you have an expertise in pediatrics, so I figured that was a good segue.
Okay.
In terms of pediatrics and OCD and neuropsychological conditions, genetics, what have you seen in growth in the past, since you've been practicing?
Yeah. So first of all, I'd like to start off by saying I agree with you. I think it's been scientifically proven that we all start as kids. So that's a good beginning point. But actually, seriously, so I had done, let's say a decade ago or so, I've been doing quite a bit of research around the genetics of OCD. And what's interesting, well, there's many things that are interesting, so that we know OCD emerges from a set of multiple different factors, part of which is genetics, so what you inherit from your parents. As it happens, those who develop OCD earlier on in life, so those with childhood onset OCD, it seems to be the case that genes play a larger role. So when you look at something called heritability or estimated heritability, when you look at, if you're going to throw all the different reasons for OCD that may pop up in an individual into a bucket, the genetic pieces for those with adult OCD would be, go between, fill that bucket about 1/4 to 40% of the way. And then with childhood onset OCD, it would be like somewhere definitely around the halfway mark. So what does this mean? Well, this was where I was really keen on trying to find maybe like some huge OCD gene about a decade ago. As it turns out, that is not how genetics work with most psychiatric disorders. It seems like it's more a combination. So there may be actually hundreds of genes that contribute. So everyone's born with something, and whatever combination you're born with may start you off with a lower risk or a higher risk. So through some IOCDF funded work and others, it has been determined that there are many different genes, something related to the synapses, which we can get into later if you want to, seem to play a role in conferring risk for OCD. But then, so that's, I guess, when people are born. So everyone's born with a different level of risk, and as you go through life, different things may happen, different factors. So with kids, we know about 1 to 3% of kids will end up with OCD. That does not mean they're going to keep it forever. So this has been another area that we've looked at is long-term outcomes. So in fact, the majority of kids who have OCD, as children, when you follow them up later, they're not going to have that full-blown OCD. So there's a lot of reasons for hope. And I'll just end off because I know there's other people here as well. To say that I think what's really crucial is that this is an illness or disease that affects the brain and personality development and, confidence and self-image, self-efficacy, all of that kind of thing. But it is really clear that the sooner you intervene, the better the chances are. So for kids, the sooner you intervene, the greater the likelihood that as adults, they're going to be doing better. So there's lots and lots of room for hope here.
Hi, I'm the poster child for when you don't intervene early. It's nice to meet you.
I wish I met you a few decades ago. Yes.
Well, you know what? Life is beautiful now, and it has been for the last decade. So I'm very fortunate. But you're absolutely right, and you tie a lot of things in together. And apparently, I was one of those who wasn't willing to let go of the OCD. I really wanted to carry it into my adulthood. So consider me an OCD overachiever. Real quick, we have some great international attendance today, and I want to give a shout out to Mario in Beirut, Lebanon. It's 2:14 a.m. there now, so thank you so much for tuning in, as well as those in Deirdre, New Hampshire, which is kind of its own country as well. Jeff,
yes.
I would love to hear from a therapeutic standpoint, from a clinical treatment therapeutic standpoint, what you've seen since you joined the field, and yeah, that's it.
Yeah, so I'll start a little bit before then. If you had OCD in the 1970s or earlier, there was nothing, right? In the 80s is when the field kind of came on the scenes. And what's interesting is people like Edna Foa and Mike Janicki, some of those folks are still around, still as part of the foundation. And they really started the field, Mike in the kind of biological end and Edna and the psychosocial treatment end, innovating exposure and response prevention. So in the 80s and 90s, really that became the field, is exposure response prevention and SSRI treatment. You hit the 2000s, and that's when I ended up at the OCD Institute. And what was interesting is that ERP was still very manualized and really focused on manualized, meaning like there was a way to do treatment and everyone kind of got the same treatment. And if people didn't get better, they were labeled treatment resistant. And it was still SSRI treatment, right? And so what you're seeing in the last now 20 years is people looking at how do we make ERP better. And so you are starting to see things like acceptance and commitment therapy. So I started self-training in ACT in 2003. There was no one doing ACT. It was just the ACT researchers doing it. Why did I look into ACT treatment? If you ask anyone here, it's because the treatments that we had were not effective for some version of people, for some section of people. So I was doing ERP. Some people were getting better. Some people weren't. I started to get curious about who were the ones who weren't and what could I do in order to get them better, right? We can't just go, oh, I worked at they called it a treatment refractory facility. If I couldn't get you better, who was going to get you better? And we're just like, what are we going to do? Right. So I think a lot of things have come from that, what I've seen in the last 20 years. I think acceptance and commitment therapy is one of those. I'm hoping that Mike will talk later on about metacognitive therapies. I don't think people have heard a ton about those. They are gaining more evidence, and more people are getting trained in those modalities. But I think, again, it's beginning to understand that when you're working with someone with OCD therapists get so excited about, I have a way of making your OCD symptoms decrease in such a way that we're like, okay, you're like 70% symptom reduction, you're done, and like kind of move on your way. Well, I didn't live the last 20 years of my life. I still am super critical of myself. I never got married, right? So what you're seeing in this kind of next iteration of psychotherapy is ERP is the core of your treatment. But as your symptoms start to reduce, we have to take care of the rest of you, right? There are developmental milestones you might have missed. There are relationships you might have missed. There's shame, guilt, loss that you didn't process, that you didn't experience, that you didn't work on. There's problems still lingering in your family. One of the bigger innovations I've seen in the last 20 years is the importance of incorporating family members. Now, Barbara Ben-Appen has been doing this work for 25, 30 years, but I would say it's only in the last 5 years where you see people are looking at what is going on in the family system, what the family is doing in a compassionate way, undermining the effectiveness of the treatment, right? How do we create communities of families and communities of people where they can inspire and have hope? So I think thinking about treatment of OCD systemically, if you leave treatment, like kind of where are my people? And for those of you that have been to the OCD conference that we do every year, like people are like, this is amazing. Well, but it's 3 days, right? So what are we doing in terms of creating community? I think that helps with relapse, but also, Stephen Smith was on the part 1, and not that long ago, he was saying how many times he was misdiagnosed, just the lack of awareness about OCD. So we get people into treatment, we get them into good treatment, we keep them from relapsing, we create a community, and now we have a bunch of advocates who are out there reducing stigma, raising awareness. So the way I think about the foundation is kind of an extension of treatment, or a way of making treatment better is we're kind of the relapse prevention toolkit, right? We're the community, we're the inspiration, we're the advocates, we're a place for you to go and participate in some ways. So I see a lot of innovation in psychotherapy, again, with people pushing away from like, we just got to do ERP, right? Because I think that's very narrow, even though it's, I think, our most powerful tool in the toolkit.
That's a great, I love that, Jeff. And I want to humbly say that I feel like I'm a testament and potentially a testament to that process, because in my own OCD journey, I was treatment resistant, very refractory. And I was somebody that did ERP for 10 months, every day, 5 days a week, residential, outpatient. And really it wasn't until the integration of ACT, integrating my family unit into it, separating myself, and like me really reestablishing what my relationships are with my thoughts, that suddenly I could engage in ERP in an even more effective way. And not only that, I really, really credit not only my continual work involuntarily with ERP, but I really credit ACT and my family support and the community with, as you said, relapse prevention. Knock wood, or who knows, that I'm uncertainty, but I've never relapsed. I've never had a relapse. And I really feel like because of ACT and because of my understanding and then continued advocacy and support in a community that I really connect with, it's just such a huge role in that. So I feel like in some way, Jeff, I don't know if it was on accident or not, I'm super blessed for it, but I think we have to do it for everybody, because it can't be random. It can't be like, oh, you happen to get lucky and get that therapist who did that thing, and you happen to get ACT when the other people did, so we have to make it more uniform.
Well, the other thing that's interesting, and I think Mike is a example of this, is that, when I took over the foundation, there were 12 facilities or programs that did intensive treatment. That was only 12 years ago. There were only 12 programs. There are like 90 that we know of that are part of us. So we're starting to see this explosion of people being interested in OCD. Again, 5, 6, 7 years ago, it was hard to find a pediatric specialist in OCD. We could barely find an OCD specialist. Now it was hard to find a pediatric OCD specialist. And now what we're starting to hear, right? How many white faces are on this panel? What we haven't done is, and where's all the cultural sensitivity? There's research showing if your native language is Spanish and you get treatment in Spanish, your outcomes are 4 times better than if you got it in English. So those are all the other ways in which we need to think about ERP works, and then how do we adapt it for all these different populations. And then the other thing that we're trying to do is that Katie O'Dunn is helping us with is people of color are going to faith-based communities. Research has shown that. Not everyone, but on average, that's where they're going. And so if we're not going into and we're not developing relationships between mental health and faith communities, there's a whole part of our population, a whole part of our community that we're not even addressing. So I think it's innovating around the treatment, but also making sure the treatment is applicable and appropriate for everyone.
Absolutely. Thank you, Jeff. And just so people know, Jeff is broadcasting from a Burlington coat factory. So I just wanted to throw that out. Also, if you have questions, please load them in. Unlike usual town halls, we won't get to as many questions, but please feel free. And always, 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 you can email us and we'll get your questions answered by anyway. Vlad, I want to turn to you. I think for everyone with an OCD diagnosis or even a mental health diagnosis of any kind, sort of your first gateway into treatment is some sort of medication. Most times, at least, not everybody, but I think for most of us. I know that I was on every SSRI known to man before I even came into treatment. As first and foremost a psychiatrist, also a clinical researcher, and obviously now, running a pharmaceutical company. What have you seen? Sort of the trajectory of medication for OCD. Starting, I guess if anafranil was the first, I don't know if it was or not, and kind of where we went from there.
Sure. And Ethan, I think as I was listening to Jeff talk about the historical context of kind of where we've been as a field, I entered the field right when, all the SSRIs were just turning, generic at that point. So we knew that these were effective agents for OCD, but they didn't work for everyone, right? And also at the same time, the success of obviously ERP and the combination of those two approaches for OCD. But what was interesting is I was running an OCD clinic that saw a lot of treatment refractory patients. It quickly became, apparent to me that, patients really aren't treatment refractory. It's we as the professionals and clinicians don't understand their disease, right? And so in some ways, it's really unfortunate. It's a term I've come to really hate, the term treatment refractory, because it makes patients feel as though they did something wrong or they have a really bad form of a disease. And that's not the case. And so as I saw some of these treatment refractory patients, I realized that they just were not serotonin responders and ERP responders. And we as a field had to understand, why are they continuing to have symptoms and how can we improve those symptoms, right? And so, to get at your question, I think what's happened is the field kind of stalled around the SSRIs. As you said, you've been on multiple ones, right? And a lot of times if, some people may respond from switching to others, but generally, I believe that a number of people who don't respond, it's because they fail to have a version of OCD that is responsive to serotonin. And then we as a field have to do better and say, okay, what are the other mechanisms? And then what we know is that there's been other mechanisms that we've begun to explore. One of obviously the augmentation strategies is adding dopamine antagonists, low dose Risperdal. All right, that's been shown to be very effective. And I think that works for some patients. So the field moved to then exploring different neurotransmitters. Unfortunately, I believe it's done so at a snail's pace, right? And so we've had little progress in some of these more novel therapies, but we have had some successes. And so I think Risperdal was proven in a double-blind placebo-controlled study to work. We've seen that as a nice augmentation strategy. Then other, novel anticonvulsants, atypical antipsychotics, as well as some glutamate modulators have begun to be used. So I think we're just at the very beginning, Ethan, of exploring other neurotransmitter systems and finally getting to the basis of, well, why do some patients respond and others don't to serotonin medicines?
That is such a huge important, well, two things I want to touch on. And Rich said, bravo, Vlad, very well said. And I know what he's referring to, which is, that what you said about science, I can't tell you how much we as a community stigmatize ourselves, that we're failing as a human being, as we're failing the medication, we're failing the treatment, we're not good enough, we're not strong enough, our brains are more broken. To be able to hear that from you and other folks and let us know, no, it's not your responsibility. You have a disorder and a disease, and it's our responsibility to figure it out. Really takes the burden and the stigma off of us. So I just wanted to highlight that. And so I agree, Rich. Bravo. The other piece of that, and we'll get to this in the future, but I think the other piece of the pharmaceutical side and the medication side for most of us is what I like to call the lab rat syndrome. It feels awful to go and without having the knowledge of what it's like to be a psychiatrist, and not knowing your side of it. For somebody that doesn't know and struggling, it feels very weird to go in and say, we're going to try you on this. We're not sure. We may have to up it. We may not have to up it. We have to decrease, increase. Nope, didn't work. Let's try something else. And you go, what are you doing? Do you not know what you're doing? Well, I don't understand. Can you talk a little bit to that just to get people understanding that, we're not just, and also where the future is going, which is to eliminate that. But in the meantime, what are you doing?
I have to tell you, I think it's frustrating for the clinicians on the phone, can maybe comment on this as well, on the line, I meant, not the phone. What are we doing? In the rest of medicine, right, we have biomarkers, we have lab tests, and we, in a very disciplined way are able to figure out, right, what is the appropriate treatment for this specific patient. Because our knowledge isn't there yet in OCD, we can't do that, right? And again, that's our shortcoming, but we have to work towards that future state where we can determine by perhaps, is it a magnetic resonance spectroscopy or a PET scan or a blood test that might tell us this person's more apt to respond to this therapy. That's where we have to bring the field work that Evelyn's done, right? Evelyn is, one of the pioneers in genetic research implicating, glutamate. One of the findings in, some of her studies is that glutamate is playing a role in some patients' OCD. That led me to, go down the path of looking towards some of these glutamate modulators. So we have to be able to connect the dots, elucidate the science, and deliver more specific treatments that are personalized for patients, like we do in oncology, like we do in cardiology. We're not there yet, but we're working towards that future state.
And we'll talk more about that future state in a minute. Thank you, Vlad. Thank you for being patient, Mike. I really appreciate it. Before we jump into it, Jeff mentioned it, and I actually would like you to define it for us. What is metacognitive approach?
So it's a really good question. So metacognitive is a really fancy word for bringing one's awareness to your thinking style or your thinking process, as opposed to the quality or validity of a particular content of thinking or thought content. The technical definition of metacognitive, I think, is the internal cognitive factors that are playing a role in monitoring, directing attention. So you can't talk about metacognitive without talking about where we put our attention. And so that's kind of, I think, one of the more or next evolution in cognitive work isn't so much on disputation or refutation of content, but looking at the behind the scenes process of thinking that's maintaining a certain awareness or attention towards certain areas like threat or danger signals. And it's a lot less likely to get wrapped up in a compulsive cycle. And I can elaborate more if you'd like.
I was going to ask you. Let's talk about why. Let's talk about why we need to head in the metacognitive direction. To your point, and it's like, the hip term is like, oh, you're talking about mindfulness. Let's be aware. But let's talk about why we need to head in that direction. What are you seeing right now, and why isn't it necessarily the most effective approach?
Well, I think we have evidence to suggest that more traditional forms of cognitive therapy that was quite effective for depression is not effective for OCD. And I think there's ample evidence to support that. I would suggest that there's reason to think, and growing evidence, as Jeff has suggested, that when we make that shift up to a process level, we have evidence suggesting similar outcomes to ERP. but there isn't a formal focus on exposure. So it's interesting to think that there might be many roads to Rome, right? So metacognitive approaches aren't intending to replace ERP, because that's still got the bulk of the research, right? That's where the heavy weight is when it comes to treatment, but it's adding a new line. And I think if you think about, the question from a behavioral perspective, what maintains the obsessive compulsive cycle? Most of us here, behaviorally trained, would know that it's the compulsion and the avoidance that tends to maintain obsessions, right? If we were to ask ourselves what non-compulsive cognitive factors maintain obsessions, now we're asking a very different academic question, right? And this is where, like Jack Rackman and other people are looking into appraisal-based models, which is still, again, at that content level. And there's evidence, and I can talk about the different schools that are doing this, from Adrian Wells to Fred Ardema, doing work at the metacognitive level, looking at the process of how you pay attention to certain styles of thinking, like worry or rumination, or even the reasoning behind why you paid attention to one thought but not another. Does that make sense?
I'm wondering
Absolutely.
if I can, Ethan,
Oh my gosh, yes, please. No, please.
Disturber. But I'm just wondering if I could jump in and ask Mike, 'cause you're the pro, and this is something I've been talking about with different patients. So, and again, I'm just an MD, so I'm not the pro here. But in terms of wrapping my head around OCD over the years, I think it's really clear. ERP, great evidence across the board, but really what you're aiming for there, obsessions don't so much matter, except how you're going to do the exposure, like how you're going to bring on the OCD, right? But really the goal of ERP seems to be, if you can just stop those rituals or compulsions or stop that avoidance, then you're good. And I guess I had a patient earlier this week where they were saying, okay, not doing I'm able to fight it, not doing these rituals anymore, but I'm constantly tormented. So those obsessions are still coming at me. And, as opposed to, what we thought back when you stop the rituals, okay, eventually the distress is going to come down. But with some people, that doesn't go away. So is it right for me to oversimplify by saying maybe the ERP, the goal there is stop those rituals that are taking over your life and the avoidance that's keeping you from living your life, and maybe something like metacognitive training that can dampen down how much it sucks to have obsessions. And sucks is a proper medical term.
It's terminology. Yeah.
So
it's
but
SUX as I've heard, right?
Okay. Yeah. So is that
yeah, I think no, I think that's basically headed in the right direction. I think if I can.
Oh, that means I'm not exactly right. I'm just headed in the right direction, but it's okay.
You're an MD. We'll give you a B. Don't
Can't blame a girl for trying.
So I would say, like, we're most of us listening and on the panel are familiar with ERP, and I would say that, if we asked kind of a basic question to sort of set the tone and how we want to think about this, which is, what do our clients with OCD need to learn to get better fundamentally? The first thing I would argue is that they need to learn that compulsions or rituals or avoidances were not needed. They're absolutely not needed. They actually make things worse. That's the first thing they need to learn. The second thing they need to learn is obsessions are scary stories, that they're not true detectors of danger or threat, that they're scary stories. And the question is how do we facilitate that learning? So ERP is fantastic at facilitating explicit, direct learning about compulsions being completely and utterly unnecessary. Like, I don't think there's anything better than ERP at doing that. But they only kind of indirectly teach you about obsessions, right? Because we're leaving the obsession alone. What can we learn indirectly, right? Implicitly from that is that maybe they don't matter, maybe they're not credible, maybe they'll go away, but we can just, not listen to them. The metacognitive folks are saying, we want to start where the disorder appears to start in a sequence. OCD starts with the O. And we want to learn a little bit more about that process. And we want to learn a little bit more about what creates the obsession. Is there anything we can help our clients determine about that process? And we want to learn how to reduce the strength of an obsession by understanding it in such a way that isn't an indirect form of learning. So we want to directly learn about the obsessive process, the styles of thinking, the beliefs, the kinds of attention and what draws our attention, to pay attention to a particular thought that then turns into an obsession, which then goes into the compulsive process. Does that help? Did I do it?
I know Jeff is dying to talk about ACT. I can feel it.
You know, I mean, ACT and metacognitive therapies, I think, are very consonant.
But in specific to Evelyn's question, because for me, I mean, I'm not a doctor either. I played a doctor in CSM Miami in 2003, which is like the pinnacle of my acting career. But my original thought, Jeff, is, you know, sitting with it, not being afraid of it, letting it be there, not saying, oh, I don't want the scary monster to be there. I'm going to think about it all the time. Let it, you know, I want to coexist with it. I want to bring that ACT mentality to it. And because of that, it will start to, you know, in theory, diminish. What do you think?
I mean, when I listened to, because I'm also, I don't know a ton about the metacognitive therapy models, which is why we invited Mike on. But what it makes me think about is, so I have a fear of heights. I still have a fear of heights. You put me on heights and I'm going to sweat, right? I no longer, though, argue with myself about like, this is uncomfortable and I hate this and I don't like sweating and I don't like, I'm like, I don't have, my body's, it's like it's digesting a sandwich. Like it's unpleasant. Not anything I can do about it. So I can enjoy the view, or I can be focused on the fact that I'm uncomfortable, right? But the thing about the reason I bring up fear of heights is because I also have this weird thing of, I have this image, usually like when I'm falling asleep, of like falling off a building. And when I'm falling off the building and I'm going towards the pavement, I actually actively stop the image of me hitting the ground. And the reason I'm doing that is because I'm treating what is happening in my interior as though it's the same quality of what happens in my exterior. And what I mean by that is, if I let myself hit the ground in my imagination, it's the same as hitting the ground in the real world. And I think it's that process of, we lost Evelyn. I think it's that process that Mike is talking about having a different relationship with our process. If I have an image that I don't want, and I'm going to treat it as though it's dangerous, rather than like, it goes back to a thought is just a thought, right? But there is all this, I think, in what Evelyn was talking about, there's a lot of this covert avoidance, it sounds like this patient might still be doing. There might still be a lot of self-reassurance. There might be, and I think what Mike is talking about is more a redirection away, not because it's dangerous, but because, don't you have other things that you want to be doing? Mike,
I love that, Jeff.
How does that overlap with what your approach?
Yeah, I think it's if we think about like a metacognitive approach as being able to decide if we want to bring a critical thinking style to a process or a flexible relationship to that process, you can't do it if you're not aware of it. Right. You have to learn to bring awareness to it before you can decide what you want to do with it. If I would just want to go, I'm just going to turn my back to it and drop it, perfectly fine. But the way I think of it is a lot of people with OCD have kind of a flawed reasoning that allows them to continue to select for very particular kinds of thoughts that then become obsessional. If that flawed reasoning is never really addressed directly, then it's going to probably sort of be there operating behind the scenes, which is why I think, and I'm completely speculating on these points, why some clients have a hard time generalizing with therapy, because that operating system, that flawed program is still running, or because they've never actually learned to recognize it as flawed. Right? That the kind of thinking that allows an obsession to continue isn't the kind of thinking we want to teach in critical thinking class, right? It's not the most helpful way to arrive at decisions. And so there is a direct opportunity, should you take it, to say, let's take a look behind the curtain of your obsession,
Mm-hmm.
right? Not at the validity of it, not about how to dispute it to get rid of it,
Mm-hmm.
but, you know, if we can simplify it, if an obsession could be simplified into like a what if doubt that popped up, why is it that you paid attention to that what if doubt
Mm-hmm.
as opposed to 100 other what if doubts? What was the process that led you to have sustained attention to this, where other thoughts you just kind of brushed off your shoulder?
Mm-hmm.
What's that about? And I think that's a metacognitive kind of awareness
Mm-hmm.
approach that's not about leave it alone or, you know, just turn your back. Although I think you could have sort of the
Mm-hmm.
meta flexibility to go and say, I'm just going to turn away from that because that's not important. Does that
Mm-hmm.
clarify?
Yeah.
I think with kids, what we do a lot is talk about OCD. You know, they give them nicknames, sort of a bit of externalizing. So it's not exactly the same thing, I know. But rather than, we don't tell them they have flawed thoughts or that kind of thing,
Mm-hmm.
it's more that you got a trickster who's on your back.
Mm-hmm.
You know, you got a bit of a bully, and the more that a bully gets, the more a bully wants. So they're never going to be satisfied.
Mm-hmm.
So instead of like, you know, seeking from the bully what they want, it's like, I know you're a bully. So I'm going to continue, and I'm going to eat my own recess food. Yeah.
Absolutely. I think, you know, Reed Wilson has been talking about this
Mm-hmm.
for a very long time, where he's not interested in going into content at all. He doesn't even
Mm-hmm.
want to deal with themes. He simply says the disorder
Mm-hmm.
to encompass everything. And that's a kind of stepping back. That's a kind of meta, right?
Mm-hmm.
And even his concept of detecting, having a client learn to detect signal from noise,
Yep.
right? That's a meta assessment of your obsessional process. That's not about validity of a thought. That's not disputing a thought. That's saying, should I have paid attention to that or not? And if it's noise, then no.
Okay,
Mm-hmm.
I like that. I like that so much better, because I was hoping we weren't going back to the land of,
No.
oh, let's analyze our thoughts and what happened to you. Like, were you
Mm-mm.
breastfed as an infant or not? And what did your
Oh.
mother do wrong to create? No, so you're not saying this at all. We're not digging into why the thought. You're
No.
digging into awareness that, oh, that's
Yeah.
And again, from an ACT perspective, it's what do you do when that shows up, and what are all the things you could do when that shows up, and also, instead of me telling you what the right option is, why don't you just try a bunch of different things? You have that obsession just showed up. I want you to try 8 different things. 2 of them can be compulsions. 2 of them can be whatever. I was in a struggle with a patient, an outpatient, and we were just in this battle of like anything different. And so she gets up and she walks around. We're on the 9th floor, and she's like, "I'm going to open up the window." And I was like, "Great, you're doing something different." And then she's like, "I'm going to throw myself out the window." And I was like, "Well, that is an option. I'd rather you not. But, and what's that like when you start to think about that?" So then she comes over and she grabs my water bottle, and she's like, "Now I'm touching your water bottle." And I'm like, "Okay, that's still different. So I'm cool with this." She then spits in my water bottle, which is also whatever, that's different. She sits down, and we're in a completely different space because she realized she just spit in my water, right? And so what I was asking her to do is, there isn't a right answer, right? I think this is what old style cognitive therapy got wrong. There's a right way to think. There's a wrong way to think. And instead, I think from an ACT perspective, this metacognitive perspective, it's like, take a step back. What happens when this shows up in a repeated way? And now let's generate all kinds of different ways that you can interact with this in a flexible way, so that you aren't in a then equals B. But I'm with Mike, like almost none of it's content. It's actually a really hard therapy to move into, because it's so non-content. It's so about process and relationship to your internal experience.
Thank you, Jeff. Yes to all of the above. I really hesitate to speak or give any insight, just because all of this is so meaningful. I do have to say that while Mike and Jeff and Evelyn were talking, I got choked up, and I don't know why. I just started to get emotional, and I think if you can see it in my eyes, I got emotional because I was just thinking, how blessed and grateful and privileged I am to even be in this conversation. Also, to see 2 psychiatrists and 2 psychologists collaborating in this conversation together to bring so much hope to the community. And it really touched me. It really did, because you know, I think it's so important, whether it's talked about or not. I feel like in some instances, it's insinuated that there's medication or there's therapy. There's psychiatrists or there's psychologists. And I mean, early on, Dr. Janicki, told me, it's probably the path to wellness is a combination of both, percentage, 20, 30, 40% medication, 70, 80, 90% treatment, but it's a combination, it's a marriage. And so seeing this marriage and now in this moment and having this conversation, and really we're all in it together, right? We're all in it to solve. It's you may think, when Vlad talks about an adjunctive treatment, it's like, oh, it's another pill on top of a pill. But if that lowers your symptomatology 3 or 4 points, which then allows you to effectively engage in treatment, well, then now we're all collaborating and we've got a win-win situation for the patient and the individual with OCD. And that's just so special, I think, and so important. So I love that we're all willing to have this conversation. Vlad, there's a question for you specifically, which will bring us into sort of the present day, which is, and my thing just updated, which is Patricia at 7:38 p.m. asked, Dr. Cora, can you talk about the drug you have in trials now? So let's talk we've talked a little about the metacognitive state and the approach to treat. Where are we? You talked about exploring glutamate. What is that looking like right now? And incidentally, I've been on a glutamate modulator off-label since 2010, and I saw pretty significant difference in my racing thoughts. So I'm super interested in what you're doing.
Sure. So when you think about behaviors and neurocircuitry and neuropharmacology, what we know about the pathways in the brain involved with OCD is that glutamate is a driver of some of those pathways, especially in some individuals who don't have a therapeutic response to serotonin medicine. So it may be that they're not dampening this glutamate outflow that sometimes gets, let's say, hyperactive, in OCD. And so we have converging lines of evidence that suggest glutamate does play an important role in some patients. And Evelyn's work in genetics showing a genetic component of glutamate in OCD patients, as well as measuring levels of glutamate in the cerebral spinal fluid of some individuals with OCD, neuroimaging that shows the same. And so what we've done is we've taken an approach of identifying a medication that dampens or lowers glutamate levels in the brain as a way to try to improve symptoms in OCD for the very purpose that you just pointed out, so that you could then engage in the ERP or other approaches behaviorally for OCD. And we believe that combination of glutamate with behavioral therapy really could lead to a better therapy. So hopefully I give you a big overview of that and address that question. Any follow-up, Ethan, on that? Or
yeah, I always have follow-up. So actually they asked, what is the drug that you have in trials now? So let's just quickly talk about the trial that you have going on.
Okay, sure. So it's called troriluzole, and it's a tripeptide prodrug of an agent called riluzole. And that agent administered at 280 milligrams once a day on top of standard of care medication. We've demonstrated some preliminary evidence that suggests that it will lower the obsessions and compulsions of OCD. And we've seen significant reductions in the YBOX score over a 12-week study. And we're trying to replicate that finding in this study. One of the hardest parts of demonstrating a drug works is to be able to show statistically that it has an effect. And our first trial, we had won at all the time points except for one, and we didn't have enough patients in the trial. So this trial is simply trying to replicate a previous finding that there seems to be a signal here, and involves a much higher number of patients so that we can definitively prove to the FDA that this in fact works or does not work. And we'll find that out, we think, in about a year or so.
It's amazing. I've been curious, is there a world where a medication that directly targets glutamate as a primary medication, as a primary first line, as opposed to an SSRI? Is SSRIs the first line for years? Is there something better?
Yeah, so I think what you're also getting at is we know SSRIs provide some benefit to many patients, right? So rather than as a first step, look at monotherapy, what we decided to do is add this on to SSRIs because we don't want to perhaps worsen symptoms by either titrating somebody off, or lower their dose. And so we believe that glutamate could be therapeutic as a monotherapy, but as a first step study, we want to prove it on top of. If that works, then we'll go and try to do a monotherapy study and see if there's a benefit. Because as you point out, there's some benefits to be on one medication as opposed to multiple medications. And perhaps some people might require multiple medications, but I think one medication would always be the preferred path, but we're not there yet in proving this medication. So we have to take it one step at a time.
And I think that's so important to hear, because I think, anyone struggling with OCD or related disorders is like, well, if that works and then that works better, we'll just make a pill of that. Like, it's so easy to feel that way. So it's so great to hear, like, well, we want to do that. We would love to do that, but we have to scientifically prove first that it works to a certain extent. And then from there, and that's awesome to hear that there's also a line of responsibility, if you will, into safety and watching out and not wanting to disrupt what is working to a certain extent before we sort of go into. I think that's huge to acknowledge. So thank you, Vlad, for that. And hopefully that answered your question as well as to what's going on. And at the end, follow up, we can put a link to Vlad's trial and Evelyn's as well. As long as we're talking about trials, then I'll jump back to Jeff and Mike, although I've heard Jeff is permanently muted. And so that's a win for us. That's what I would call a cure. But anyway, incidentally, Jane asked me, what is a glutamate modulator you take, if you don't mind me saying? No, I don't mind saying at all. I'm on a glutamate modulator called Namenda. And there were two schools of thought. Vlad and I have had this conversation previously. Sort of the Harvard approach was Namenda. The Yale approach was Riluzole. Dr. Mike Janicki put me on Namenda. I thought I was special in 2010 until I found out he put all the patients at the OCDI on Namenda. So, again, there's different glutamate modulators with different impacts and effects. I'm on it still because I don't want to rock the boat. It's and quite frankly, I have no clue how effective my medications are. I was on medications prior to getting better. I got therapy on medications. I got better. It's the therapy. It's the medication. It's both. And so, I embrace it all, and whatever I can do to keep myself well is my approach. Evelyn, I wanted to call on you so you don't feel interrupty, which is also a technical term. Sucks and interrupty. We're teaching lots today. Tell me a little bit about your trial and what you're doing right now in pediatrics.
Maybe if I could just initially, so back in the day, so actually we published a paper. I think you were likely included in this study when Dr. Janicki was putting everyone on memantine in addition to SSRI. So what we did is we took a look and we published this paper. We looked. So it turns out he didn't put everyone on memantine, maybe just his favorite patients like you. Hard to say. But anyway, nonetheless, joking. So nonetheless, we actually looked at those who had memantine and those who didn't when they were actively doing CBT. And it was a little bit of a battle. So when we were publishing this paper, I was envisioning memantine as helping out the CBT, not helping out the SSRI. But they really pushed it to say this is an SRI augmenting agent. So I think the big point here is that these treatments need to come together. So with all the faces here, I think what we're representing are like sadly, there is not a one size fits all answer where you're going to have as good of a response as you want in everyone. But we're lucky that we've come across these different aspects where they are helpful in combination. And I think in particular, there's some of these that can really help with the learning that takes place in the context of cognitive or behavioral therapy. But one other piece is that we've been looking at anti-inflammatories. So I think the role of inflammation and neuroinflammation, meaning inflammation in your brain, there's lots of evidence that's been coming out in recent years in depression and other disorders. And also, we've looked at it in kids with OCD. So not just the ones with PANS or PANDAS, but looks like there is this tendency to have maybe overreactive systems that respond with inflammation that also happens in the brain. So we are doing a study that looks at an anti-inflammatory just in regular old OCD in childhood. So I think that's another pathway. But I do think that it's not that there's one answer and not an answer. I think how we're able to pull these pieces together, and eventually if we can get to the point where we can sort out who are the folks with OCD who may respond best to specific aspects, then that's where we want to head. And yeah, so NSAIDs is what I'm just looking at the comments. So NSAID, yeah, it's an NSAID, but we're doing a trial of celecoxib. It's not over the counter. Ibuprofen or naproxen, these are other NSAIDs that you don't need a prescription for, but they're less selective. So not to be boring and geeky, but yeah, so because celecoxib is selective COX-2 inhibitor, gives us reason to believe that it has a better chance at responding, but there are other anti-inflammatories where there's been sort of case reports, that kind of thing.
Ethan, I just want to add, I think what Evelyn's doing is really groundbreaking, and I think the field of neuroimmunology is going to be really key to some of our future research. We've seen what understanding the immune system has done for cancers, right? 10 years ago, people would have thought you're crazy if you said that you'd have immune-based therapies that would, in some patients, cure certain cancers, and that's exactly what we've seen with the anti-PD-1s and anti-CTLA in certain forms of melanoma and lung cancers and others, right? And that if you can harness the immune system to not become overactive and cause inflammation that causes damage, you can then, revert to a normal baseline of functioning. And I think in the brain, it's an understudied area that I think not only could be at the root cause of some forms of OCD or depression, but also diseases like Alzheimer's and Parkinson's, that for some reason, some individuals have a hyperactive immune system that starts actually attacking certain parts of your brain, causing inflammation. And we have to understand that better, target it better, and try to decrease those inflammatory responses.
Absolutely. I love, I'm just thinking about go ahead, Evelyn.
No, just saying, so another thing we've done is that we've shown, so with the genetic, it all comes full circle. So we have done different studies showing that actually folks who have OCD are much more likely to have inflammatory conditions. And also in one of our genetics trials, not only, so their relatives are also more likely to have certain things like eczema or rheumatoid arthritis and other things. So there's something in the genes that there's making a hyper responsiveness there. And it doesn't just go with OCD, but it all comes together. So that's why I think we need to take out, a very broad approach here. And then there's lots of different factors involved. Also involving are we short for time? Are we out of time?
No, we go till 8:30.
Okay, that's why I was talking so
Oh, wait,
fast.
Should I not have said that to you? No, kidding.
No. Okay. Oh, whoops. Okay, well, let me just make myself comfortable here. So, no, I'm joking. No, but I think there's also, the microbiome was brought up. So this connection between the gut and the brain-gut connection. So, in terms of inflammatory or protective response against the world, the gut is one of those areas where it's kind of open to attack, if you will, from microorganisms. So you eat something, it comes in. So as it turns out, the gut is full of microflora, all kinds of organisms and everyone's is somewhat unique, and they do a better or worse job at fighting or acting as the front line of defense, so that those things don't have an impact on the body, causing things like neuroinflammation. So people are looking at microbiome. So that is one of the things we're going to be looking at in our anti-inflammatory study. So the kid way of saying what I'm talking about is we're looking at poop. So just to cut right through it. So basically what happens in the poop that comes out, it's okay, everyone poops.
You can prove that too. Everyone's a kid, everyone poops. We're on fire tonight. We should publish together.
Yeah. So no, as it turns out, and there's so you can look at the flora or the thing that comes out, so get a sense of what the gut is like and how good it is or not good at defending against inflammation. So we're going to be in this inflammatory piece, we're going to be looking at the poop pre and post-treatment, and see maybe there's a correlation between how much that has changed or indications of what's in there with how much the OCD is improved, which may be related to neuroinflammation. But I'm going to stop using the word poop now.
You can never get enough poop. So
Okay,
I'm actually going to jump. I have a method to my madness. Thank you, Evelyn. One quick question. I thought Felice brought up a great point, and I genuinely don't know the answer. Then I'm going to jump back to Jeff and Mike, even though Jeff is permanently muted. I can throw this to either Vlad or Evelyn, but it's a great question. Felice at 7:53 p.m. wrote, SSRIs help with depression and anxiety, but I don't think it's really the main issue with OCD, or people wouldn't have to take such high doses. What is the methodology or the pharmacological reason, physiological reason for the high doses of SSRIs?
I can maybe start, and then Evelyn can add in. So there's a couple different schools of thought around this. One is actually the serotonin system does interact with the glutamate system. And so in many individuals, serotonin will actually dampen glutamate. And people who don't respond, there may be a failure to affect the glutamate system appropriately. So that's one school of thought. With serotonin, there's also important evidence tying it to something called brain-derived neurotrophic factor, which helps with, let's say, neuronal resilience. People believe that if you treat somebody with an SSRI, you also increase your endogenous growth factors that might help with repair from inflammation and other things as well. So there's a couple different mechanisms by which serotonin could affect patients with OCD.
Thank you, Vlad. Evelyn, any thoughts?
Yeah, I'll just add in one piece, is that Michael Block, who, he's meta-analysis guy, meaning he seems to be the guy, he's at Yale, and he's a master in terms of being able to look at all the studies that have been done in an area, pull it all together, do fancy math, and then say, okay, as opposed to looking at one or the other, what is the whole signal that's coming out? So he's done some work that kind of challenges the notion that higher doses in SSRIs are more effective in adults, and in kids, he says that's the same, although looking at the graphs, I disagree with him. But so it's not necessarily the case that it requires higher doses. That does not mean that you shouldn't try higher doses, because I've seen so many individuals where lower dose doesn't work and higher dose does. So, but I think one thing as well, just to point out, and I think I'm not saying anything that you don't all know, but sometimes I'll find with people I'm working with, they think, okay, it's an antidepressant, but maybe it's going to be like a side thing. It's not really proven in OCD. It actually is really proven in OCD. So it's really like the SSRIs are really for real proven for depression and for anxiety, but also for realsies in people who have OCD and not other anxiety disorders, not depression, that it seems to help. But I do agree that OCD is a different beast. It's a distinct thing.
So thank you, Felice. That's a great question. Everybody has great questions. That was a great question as well. I'm going to transition over to Mike and Jeff again. I want to do that by pulling. You don't need to pull it up, Jess, but CanTT made a comment, and I'm not calling you out. It says same story for 40 years. Medication along with therapy, no cure, unfortunately. It is unfortunate there's not a cure, but I just had this conversation with Liz McInvale on Tuesday night, and I just want to reiterate, and this is how I'm going to tie it back in, is to Jeff's point, the goal in treatment and therapy and the cooperation and collaboration between everybody, even though there isn't a cure, is to not live a functional life. It's to live a serene and joyous and happy life. Doesn't mean that's going to be, well, I like to say a full life, right? Because life isn't just joy and happiness. But the reality is that life with OCD can be achieved. It absolutely can. You have to surrender fully from a therapeutic ERP Act therapeutic standpoint. You have to surrender fully to your biggest fears and give in 100% and be willing to reach that top of your hierarchy. But that life can be achieved. Doesn't mean that OCD isn't going to flare up or get annoying. But I know so many folks, including myself, whose lives are so phenomenal because of this community, because of therapy available, both medication and clinical treatment. So it's very, very important that when you're in the midst of treatment or in the midst of ERP, in the midst of an OCD crisis, it can feel so exhausting. It can feel so debilitating. It feels so painful. And if you're in treatment, you're like, if this is treatment, I don't want to do this every day for the rest of my life. I know that feeling, and I can promise you that that is not the goal. The goal is to not do that the rest of your life. The goal is to focus on your life, right? But in order to do that, it's just working through that process, being afraid to be scared, live with that uncertainty. And in doing that, you can live a pretty phenomenal life. There are days when I don't think about OCD, when I forget I have it, that I feel cured. I may not be cured, but I feel like it. And there are other days when I'm not, and that's okay. No different than, my friends with MS, that some days they're amazing. One morning they wake up, they have a flare up. They didn't do anything to cause it. They just did. And, and that's, so I just wanted to point that out, because it is unfortunate there's not a cure, but what we have right now, if you can access it, is really magnificent. And that's our goal: effective, affordable, accessible treatment for everyone. That's what we do. That's why we do it. Mike, to that point, I don't have a point. I know you have thoughts, though. So hit me with your thoughts before we let Jeff unmute himself. Where are we headed? What is the implementation of Oh, no, wrong. I do have a thought. Let's talk a little bit about, as long as we're talking about OCD and feeling the drudges of it, let's talk about shame.
Before I have thoughts on shame, can I react to what you were saying?
100%.
Sort of the drudgery and the it's such a slog to live with OCD, and how it can be quite difficult. Claire Weeks, back in the early 1970s, and she did a lot of amazing work in panic disorder before panic disorder was even a diagnosis. She's quoted as saying that recovery lies not within the elimination of symptoms, right? It's not that symptoms are gone, it's that symptoms don't matter anymore. So I think it's an important but pivotal distinction to help our clients live with, that if we're constantly fighting for the elimination of symptoms, you're still focusing on symptoms. And we only have a finite amount of attention, right? And if my attention is focused on constantly monitoring my SUDS, I'm not focusing on other things, right? And I've said to clients before, and this directly relates to shame, if I can find a segue, which is, do you have the capacity to observe a job well done? Do you have the capacity to sort of step back and take that in? Which is also synonymous with taking pride in something. And people with OCD have a really, really difficult time actually looking back at things they've done and saying, it's a job well done, I can take pride in it. And I think it's because they're mired in shame. And so a lot of my thoughts on shame has been the last couple years looking at clients and wondering why they're not making the kind of progress I'd like them to make. And when I listened to them a little bit closer, I found that the word anxiety was being used too much as a catch-all, right? It's shorthand. You're anxious about something, but they weren't afraid. They weren't fearful. They were ashamed. And that's a very different monster, right? Like we try to think of all negative emotions as being rooted in the same thing, but they're not. That fear is a different monster than shame. And so can we be more precise with what the client is reacting to? So if someone's got OCD that feels, from what I think could be a shame-driven kind of OCD, where either it's the content of their obsessions that's driving shame instead of fear. So if you think of like taboo obsessions, what if I'm a pedophile? What if I'm a serial killer? Those kinds of taboo themes, they might provoke fear, but they're definitely going to provoke shame. And a few things we know about shame, or that we're beginning to know a lot more about shame, is that it doesn't seem to habituate. Fear sometimes habituates, right? But shame doesn't seem to. There seems to be a lot more evidence that shame is linked to disgust, right? And disgust is a much more primitive, affective response. It's plenty of evidence showing that doesn't seem to habituate. So it impacts the way we talk with our clients about shame. It impacts the treatment approach. So when we think, and I know I'm talking a lot, but I'm getting to a point. I think that as therapists learning moving forward to identify not just anxiety and fear-based drivers of their OCD, to also help them assess for and learn the shame-based drivers of OCD, and to have different language and therefore different and subtle treatment approaches. For instance, we know that exposure to, say, embarrassment can be helpful. I would say embarrassment is kind of a small s shame, right? Embarrassment is I think, more consistent with a shame emotion than it is a fear emotion, but it seems to be affected with exposure. But if you take, say, someone who's caught up in, say, humiliation, would we do exposure to humiliation? That seems a little bit more dicey and more problematic. And I think for a reason, because that's a big kind of shame. And I think the differences lie here. Shame is a core emotion like fear, like anger, like sadness. We have it, we don't like it, but we have it, right? Therefore, how we relate to it matters, right? So we relate to fear. We don't try to extinguish and get rid of fear. We don't want to extinguish and get rid of shame. What we want to do is we want to learn that there is shame, the normal, common emotion that actually has evolutionary value, and I can unpack that if we want. And then there's toxic shame. And toxic shame is the kind of shame we see a lot within OCD. It's the shame that's all about, when I feel this emotional experience, I immediately move into self-criticism, self-punishment, self-blame. I attack my character. I isolate. I withdraw. I turn away. And that actually prevents learning something new or relating in a new, more helpful way to the emotion. And so that's where a lot of my work has been focused recently, is helping people unpack that their reaction or their relationship to shame can be changed, and we can move away from a toxic relationship that keeps people increased levels of depression and suicidality and isolation, and move them towards a different relationship to shame, much like we've done with fear. And I'll stop and see if there are questions about that.
There's so many individuals relating shame, low self-esteem, confidence, low self-worth, a lot of negative emotions come along with OCD. Katie wrote, yep, I relate to every single ounce of that. Love Lana, who's hi, love, good to see you. I think shame is the most damaging of all, full of that one myself. Stuart wrote, thank you for talking about shame. It is exactly the issue. Clearly you're resonating. Jeff, what are your thoughts?
Yeah, Mike just did a webinar for us on shame. So this is one of the other reasons why I wanted to pull him on, because we are hearing, again, these different themes that are coming up. So one of the things I say to people that I'm working with is, if you begin to think about emotions more as information, right? This is a little bit of meta, like, let's take a step away. When you're feeling anxious, what is anxiety telling you as information, right? That you may or may not be in danger. When you're angry, what is anger giving you as information? On average, it's, I'm not getting what I want, or I'm being harmed in some way that this doesn't feel good to me. If I'm sad, what is that information about? Typically about loss. Shame and embarrassment, guilt. I've done something that I'm not proud of. It breaks my values. So the way that Mike was saying, you actually have to have a different treatment plan for those. You have to have different interventions for those. And so if we're treating everything, and in the way that Mike was talking about, my experience also, folks that have chronic anxiety use anxiety for all of their emotions. And then the problem with that, though, is that you have to have a different intervention and a different response to anxiety versus anger versus et cetera. So you're seeing this upsurge also in, again, just kind of a more complicated psychotherapy field of what do we wrap around ERP? Well, we've done several town halls on self-compassion, right? That's the response to shame, not exposure. It's, although, again, self-compassion could be a version of exposure, right? But it's a different way of talking. It's a different way of relating. It's a different way of focusing on what we're focusing on. So again, I see this more complex way of doing psychotherapy with people as, again, making people more resilient so that when they are done with treatment, the volume is turned down. And the way that you guys are talking about, like, symptoms are there and kind of, so what? And so let me move forward, because the more it's at a 30 and I need it down to a 10, well, oof, right. So then you're spending all of your time in that tug of war.
Jeff, where does the training of new therapists need to go? Are we too early to touch, as we train therapists that are currently, getting their master's or doctorate in this stuff? Do we need more research? How do we bring about this new wave of treatment?
Yeah, I think that there is for example, so we've been running our Behavior Therapy Training Institute. So this is a beginning of how you learn to be an OCD specialist. This was, started by this organization in 1994, trained a couple thousand people, which still is not very many, doesn't also make them OCD specialists. We currently have 3,500 people on a wait list. So to me, what that means is there's a lot of interest in this. And what we continue to find is that all of this is going to be solved by systemically partnering with people. So again, we invited Stephen on to talk about an OCD because he's doing all this cool stuff with insurance and insurance companies. He's getting traction in the way that no one was. He's getting teletherapy out there. When Mike and I are part of this Facebook group, and when people say, oh, I can't get into a BTTI, what do? There are 5 people, 10 people, including Mike, that's like, you know what, I'm running consultation groups. So you're seeing this really amazing interest in learning to be an OCD specialist. And that is what we're trying to do. We're trying to be, that's one of the things that the organization has always done well, that we would like to kind of be the center of, but we don't have enough people to do that. So, we opened up our faculty we just invited another 20 people to be trainers with us. And so, but I also am like constantly fighting with everyone about, like, we can't don't look to the foundation to solve all the problems in the OCD community, because there's a lot, and we need partnerships, and we need people stepping up, and we need people like Mike and Evelyn and Vlad, who are training people, right? And taking the time to do town halls like this. Prior to COVID, we didn't do any of this kind of stuff, this level of outreach. And so it's more about, again, what the silver lining for this community with COVID is it brought us together in this virtual community to do lots of education, lots of community building, lots of sharing about what's going on out there. So I think it's a lot of, again, just kind of all of us understanding that we all have to solve it together. And again, that's the cool thing about the conference is you have the researchers, and you have the therapists, and you have the people doing cutting edge, and you have people doing the 101s, and you have people with lived experience, and everyone's in there teaching and learning from each other. And I just think that's awesome.
Well, it takes an army. We're all here doing different things in different ways, and all coming together for one common purpose. And that's amazing. And I love that. One more quick question for Mike, and then I want to jump back down. I know we've got 10 minutes. Mike, great. I don't know if it's a great question, but John, I appreciate the question. Any books on metatherapy?
Well, there's 2 books, and I think there's a third coming out. One is Adrian Wells, Metacognitive Therapy for Anxiety. There's a whole chapter on it. I don't know if I have it with me. Actually, it's for anxiety and depression. The entire chapter on OCD. Again, the research for that particular approach in OCD is still accumulating evidence. There's a bit more research done. I think 2 or 3 RCTs for inference-based CBT, and around 20 or 30 other types of research supporting it. And that one's just called Obsessive Compulsive Disorder Clinician's Handbook. You'd have to Google inference-based approach to OCD. These guys, Frederick Ardema and the late Kieran O'Connor, originated this specifically as a cognitive or metacognitive treatment for OCD. And I know Fred is in the midst of writing a self-help book to sort of simplify some of these complex topics into a self-help book for OCD. They do have a clinician's handbook. It's more written for clinicians. So inference-based approach for OCD, you'll find the book on their website. But as far as other books go, not not sure. I know Reed Wilson is launching some stuff coming up in the next couple of weeks, and his approach is quite similar. And he's always sort of the master with words. He makes things so simple. So I think that's something to keep an eye out for too.
Thank you, Mike. Yeah, we love a read. If you find a book on Metamucil, that's the wrong thing. Don't buy that. Although Evelyn is into poop, so maybe that's a win. I don't know. But a great segue into Evelyn and Vlad. You're welcome. I'm a brilliant guy. Before a super quick question, then I want to jump to targeted medicine, because as Vlad touched on, that is the future, and it's so important to talk about because it alleviates the lab rat syndrome. But real quick, Dr. DJ at 8 p.m. asked, I heard today that there's a difference between OCD from the amygdala and OCD from the prefrontal cortex. Is there anything to that? Go ahead, Evelyn.
So I think OCD is so complex. And, when I started out a bunch of years back, they would talk about the corticostriato-thalamico-cortical circuit, and then there's this argument that, or what I used to say is that OCD is like an anxiety disorder, a thinker's anxiety disorder kind of thing. So referencing that this front part of the brain here, the more evolved part of the brain versus, rats and so forth. That seems to be connected with OCD versus the amygdala, which is sort of at the base, which is connected with fear. I think it's really complicated. So, surprise. But I think I know that there's been great collaborations that have been done by groups like the PGC, where they pull together thousands of brain scans of individuals with OCD. So my takeaway would not be that, like, some people have the kind of OCD where it's the amygdala and some people have it where it's more prefrontal cortex. I think it's that it's a complicated disorder. Like when I was talking about genetics way back, it's not that there's two genes and two types of OCD. It's that there is it's complicated. There's involvement of a lot of different brain structures. And definitely one of the areas in OCD is the insula, so the connection with disgust. Yeah, sorry. Okay, that wasn't very articulate. Vlad, maybe. No. Should we do take two?
No, that was great. It's so complex. I'm happy that a smarter person answered first, so I'm glad Evelyn gave us that answer. But I agree. I think that in different individuals, you have a different interplay between brain regions, right? And just as there's not, as everyone said, one genetic cause, there's multiple brain regions involved. These are complex behaviors and thoughts, and we know how different they are for each individual. So I wouldn't be so focused on necessarily, what brain regions, but rather how do we use behavioral therapy? How do we use pharmacotherapy to better treat these disorders? And we have a long way to go, right? Our understanding of these areas, we're just at the very beginning.
Vlad, let's stick with you. Let's talk about targeted medicine. You mentioned in cancer and other areas. What is it? What does it look like? Are we going to get there? Time horizon?
We'll get there. If I knew what those areas were, we'd be there today, right? Evelyn, I think would probably comment the same and invite her to talk about this a little bit. But we're not even at the point where we can speculate where those personalized therapies are going to go in OCD yet, right? And we have, thanks to the OCD Foundation and other groups in the NIH, we have begun to lay out those areas, but we're at the infancy of research here. So I have a slightly different view. Until we can get there in a personalized way, what we have to do is explore different neurotransmitters and different novel medications that might affect these pathways. And we have to do it much quicker because drug development takes too long, right? People can't wait. For example, it's been about 20 years since we've been trying to understand whether this glutamate pathway is going to be an important therapy. That's not acceptable, right? We need more research in OCD. We need more research in different novel targets, and then we have to cycle through them much quicker. And we have some really good models from other disease areas where they've made quicker progress. And oncology is a great example of the speed by which they get to human studies rather than too much time spent on preclinical models that don't translate to humans, and the speed at which you cycle through and you look for signals and you run basket trials, and you then invest more in areas that clinically are working out. We can then backfill once we know what the therapies are and whether or not they alleviate people's symptoms. We can backfill then how do we pre-select people who are going to respond to that. But we have to find better treatments before we can get to that point. I don't know, Evelyn, do you want to maybe add to that?
Yeah, no, I totally agree. And I think this applies to not just pharmacologic treatment, but the treatments we're talking about tonight. So exposure response prevention, metacognitive training. We're not on opposing sides of the fence here. I think I think the answer might be all of the above, but can we find a way who fits best with different aspects? So we've certainly done with our kids, we've looked at inflammatory, we've actually just using spit or saliva samples, we found out that kids have more inflammatory markers. So maybe that's going to signal the ones where you can help by adding an anti-inflammatory. But I totally agree. I think where we need to start is by maybe investing, and Jeff and Ethan being the charming guys that you are, going out and getting more money invested in research. So I think this notion of metacognitive therapy, it's fantastic, but I think in terms of like the level of evidence, I know there's some stuff out there, but there's a ways to go. And it seems like there is really something there. Same with these glutamatergic medications, but there needs to be an investment to say, okay, we're going to see if this works and look in a scientific way. And then we're going to push it forward in the BTTIs and so forth. So I think the answer isn't which one of these, but let's invest in the things that show promise, like metacognitive therapy, like the glutamatergic meds, maybe the anti-inflammatories, follow that up. And then, the IOCDF can figure out the way to solve all the problems of the world.
No problem. Thank you so much, Vlad and Evelyn. Super quickly, we're out of time. And I want to give everyone sort of final thoughts on the future of OCD and let everyone hear as a last volley of hope. I do want to quickly announce there's some great links that Jess posted in the comment thread. So thank you, Jess. One is a link to Dr. Stewart's trial if you're interested in the pediatric trial. Another link is to Dr. Korik's trial. You can find those both in your comment threads, whatever platform you're on, as well as Dr. Wilson's books. So some great comments, some great suggestions, and all of the above. So check out the comment threads. Let's wrap up. Final thoughts. Vlad, I'll start with you.
Yeah. So, I think what I'm most hopeful and encouraged by is this incredible community that you have in OCD and the IOCD Foundation. It's really special. And in medicine, where we make our greatest advances is when you see concerted efforts by patients, family members, advocacy groups, researchers, clinicians, therapists, all coming together to fight this illness. And when I look back over my career, it's because of this group and this community that there have been so many strides in behavioral therapy as well as in medical research. And we just have to keep at it and work towards what we all should work towards as a cure for this disease.
Thank you so much, Vlad. Mike.
I am very grateful to be a part of this community and to be a part of this panel. I think the future is quite hopeful. I think we're getting much more precision than where we were 20 years ago. I think we're getting really interesting ideas and platforms to disseminate those ideas and pay attention and then test them and see if they can hold water. And I'm really excited to be a part of it as sort of early mid-career professionals. See where this goes in the next 30 years is quite exciting and I think quite hopeful.
Thank you, Mike. Really appreciate it. Jeff.
Yeah, I mean, so OCD symptoms are you safe? Are you certain or not? It's very binary. I think treatment for a long time was very binary. I think it was do exposure or you're screwed. You can't ever do compulsions. It was very binary. What I think is really cool about the direction is that there is so much flexibility and willingness to be to experiment, not in an unrigorous way, right? Celery juice does not cure OCD, but we can't stay with like, this works, and so we got to do it this way. I think I'm seeing this kind of really cool complexity in the way that our biological folks are like, this is biologically very complicated. Psychologically, it's very complicated. We need to have complicated treatments, I think, to address this. And this is what I'm seeing going on. And I love also this increased collaboration between the psychotherapy, psychosocial folks and the medical biological folks.
Thank you, Jeff. Evelyn, I want you to know that I care about you. And the reason I care about you is because I called on you last because I didn't want you to feel like other people were waiting to speak. I wanted you to be able to give final words, completely pressure-free, knowing it didn't matter how long you went, but it matters a little bit. Go ahead, Evelyn. Final thoughts.
And you represent all women everywhere.
Ethan thinks I have a little bit of interpersonal sensitivity issues. It's okay. Maybe, maybe not. It's okay. Maybe, maybe not. I have to live with the uncertainty. But no, so really, I feel like I've taken up enough time, but just want to say.
Oh my gosh, no, I was being sarcastic. Please, listen.
No, but really, my thank you goes out to the IOCDF. I was a young whippersnapper, whatever, 15, 20 years ago, and they've helped me. And without their support, quite frankly, all of this, whatever I'm doing, it would have gone in a different direction. So I really think we're moving forward in terms of sorting out better ways to help people who are suffering with OCD through no fault of their own. This is the big takeaway. So whatever I said about Jeanette, it's no one asks for this, and there is a ton of hope. So just thank you.
Thank you, Evelyn. I really appreciate that. And Carissa, yes, for anybody that didn't catch the beginning of this is available after on Facebook, on YouTube, on Twitch. You can visit the IOCDF pages on all of those platforms and look through this and, frankly, all of our live streams over the past 2 years. So with that, I want to thank Mike, Dr. Szymanski, Dr. Stewart, and Dr. Korek for taking their time this evening to be here. I want to thank, obviously, all of you for commenting. Great questions, great engagement. I hope you found this helpful and supportive. There is a ton of hope. I got so excited during this. There's so much hope and so many reasons to be excited. You know, we're all a part of this community, and we're all a part of this process, the advocacy process, and chipping away at this beast, this mountain. So the mountain will fall, and we're all contributing to it. So thank you all to my panel as well as the viewers. Super quick housekeeping. As always, I want to thank the IOCDF and of course Jess behind the scenes for helping out. For all the upcoming virtual streams and content, you can visit iocdf.org/peace of mind. And then real quick, I know we're running out of time, but I'll plug it quickly. Registration is open. Thank you, Jess, for posting that. Appreciate it. That's info@iocdf.org/peace of mind. Also, registration is open for the online OCD camp. It is created especially for youth between the ages of 6 to 17. There's the link. You can find out all about it. Also, next week, Lunch and Learn with Dr. Liz on self-care, and following that, a town hall Thursday night, navigating the holidays from an interfaith perspective with Katie O'Dunn. If you haven't already, you want to be notified about all the programming the IOCDF is having over the next month. Be sure to subscribe and follow on Facebook, YouTube, and Twitch. With that, thank you all so much for spending your Thursday evening with us. If you have any questions whatsoever, and if you have questions for any of the panels, please don't hesitate to reach out. Don't hesitate to reach out ever to the IOCDF at info@iocdf.org. Anything that you need, we're always here to support. Also, if you have questions, I know we didn't get to a lot of questions, and I apologize for that. If you have questions for Mike, Jeff, Evelyn, or Vlad, please feel free to email us at iocdf.org. We'll make sure we get the questions to them and get your questions answered. With that, have a wonderful evening. Stay safe, stay vigilant, feel the feels. Don't let OCD off the hook, and we'll see you next time. Have a good night.